Hi, my name is Vic Padival, and for the July Journal Club, we will be discussing the article by Roblin et al. Titled Addition of Azathioprine to the Switch of an Anti-TNF in Patients with IBD in Clinical Relapse with Undetectable anti-TNF trough levels and antidrug antibodies, a prospective randomized trial. Loss of response is a significant issue with the implementation of anti-TNF agents and is expected to be between 13 to 20% with both infliximab and adalimumab, and with certain studies even reporting up to 25% with adalimumab. And more specifically, immunogenicity is a common cause of loss of response and is estimated to be approximately 20% in the anti-TNF patient population. Previous literature has demonstrated that 1. Biologic-naive patients with active Crohn's disease are at decreased risk of immunogenicity at the end of a 12-month follow-up if they had received combination therapy with an immunomodulator, either thiopurine or methotrexate. And 2. Biologic-naive patients with moderate to severe Crohn's disease are more likely to be in steroid-free remission at the end of 26 weeks if they underwent combination therapy with infliximab plus azathioprine than with either medication as monotherapy. The primary aim of this study was to compare differences in strategy after a patient had loss of response secondary to immune-mediated failure to an appropriately dosed first anti-TNF agent. These patients were randomized to either monotherapy with a second anti-TNF agent or in combination therapy with azathioprine. Clinical failure was defined using Harvey-Bradshaw Index score greater than or equal to 5, associated with fecal calprotectin greater than 250 for Crohn's disease, and Mayo score greater than 5 with endoscopic subscore greater than 1 for ulcerative colitis. This Kaplan-Meier curve demonstrates that a significant difference in duration of treatment without clinical failure was found starting at 15 months of therapy. This effect, or lack of clinical failure, was maintained through 2-year follow-up. Notably, 2 factors were associated with this. 1. Combination therapy, and 2. Negative history of pharmacokinetic failure throughout the study. In comparison, pharmacokinetic failure was defined as undetectable drug levels with high antibody levels. The duration of time without pharmacokinetic failure was significantly different between the groups at 12 months duration, and the factor associated with this was again combination therapy. As previously hinted, at the end of the 2-year study period, 87% of patients with clinical failure had also developed pharmacokinetic failure. The study's strengths included implementation of objective markers instead of symptom-based or patient-reported data, and this information was followed longitudinally for 2 years. This follow-up is longer than several other trials evaluating immunogenicity and pharmacokinetics with combination therapy. Additionally, maintaining this 2-year follow-up captured the significant difference in clinical failure noted at 15 months. Also, this does differ somewhat versus prior similar studies with only inclusion of patients who demonstrated immunogenicity as a suspected etiology of loss of response. Several limitations preclude the generalizability when considering management decisions following failure of a first anti-TNF agent. Metabolite levels of 6-thioguanine nucleotide were not checked, and thus dosing was not modified. This begs the question, would a change in azathioprine dose have yielded similar differences in clinical or pharmacokinetic failure or impacted duration at which a difference was noted? This is only applicable to the use of combination therapy with azathioprine and not methotrexate. 3. The severity and active disease of the patients enrolled in the study prevented safe inclusion of azathioprine monotherapy. And finally, while this was an open-label study, pharmacokinetic results were blinded until the end of the study, although the same was not clearly stated for data defining clinical failure. This study concludes that after immune-mediated loss of response to a first anti-TNF biologic, again this scenario being dose optimization, undetectable drug levels, and high antibody levels, that the use of azathioprine with a second anti-TNF agent is associated with decreased risk of both clinical and pharmacokinetic failure. Importantly, the study authors do say that although optimal duration of combination therapy is unclear, that the study's effects were most observed after the 12 to 15 month mark following biologic switch, and this was both again true for clinical and pharmacokinetic failure risk.